Welcome to this morning's webinar, and we're going to be addressing the integration of mental and physical health today. This is the first of a new series of webinars offered to you through Going on Offense on the best practices of managing population mental health. Before I introduce my guest panelists for today, I would like to share the background behind this new series of webinars. 23 years ago, two very innovative leaders in the mental health industry got together and envisioned a whole new way of managing mental health. Instead of healthcare providers making more money by providing more services, which is how traditional healthcare works, they saw how broken the system was, and particularly how broken managed mental health was. What if we could align all the incentives with employers, who are the ones who pay for healthcare, and the way to make more money was keeping people healthy? Well, myself, having run psychiatric hospitals in my own career for many years, where I felt like I sat at the bottom of the cliff, and the more people that fell off the cliff, the better for me. My goal as a hospital administrator was to keep my hospital full. I was eager to join this new innovative solution where there was a much better alignment with the customer of healthcare, the employer, and the goal was to put up fences at the top of the cliff and keep people from falling off in the first place. And I've had the privilege of being involved in this new innovative healthcare model for the last 23 years through a company called Behavioral Health Strategies. The need to address the crisis of mental health has never been greater. And for this reason, we have decided to share the lessons or best practices, or you might call them secrets of success, which we have learned over the last 23 years by managing population mental health in a very innovative model. Each webinar will be much shorter than our previous webinars, and we'll try to keep it to about 30 minutes. We'll spend about 20 minutes of presentation and discussion, and then open up for about 10 minutes of questions and answers. Now, to describe these two leaders I mentioned earlier, one was the executive director of a large psychiatric hospital here in Utah, and the other was a founder of a preventive level of mental health care that was far more than a typical employee assistance program. They were able to prove through this new model that you can offer better services for less cost when the focus is on prevention and early intervention. We're excited to share with you these best practices, and we'll be sharing one during each week's webinar. Today, we'll be talking about the need to integrate physical health with mental health. As an industry, we have treated these two separate silos, and we need to now integrate them instead of treating them as two separate areas. One of the best catalysts for making this integration happen is the primary care physician. However, most primary care physicians don't get paid to create this integration because of the traditional fee-for-service model of paying for healthcare. One exception to this is direct primary care, where physicians are paid on a retainer basis, and all the incentives are now aligned with the patient to keep them healthy in the first place. I'm honored to have with me today a very good friend of mine and a direct primary care physician who has also been one of the pioneers of this direct primary care movement, Dr. Mark Tomasulo, the founder of PeakMed. And I'm going to give Dr. Mark a couple of minutes to introduce himself and talk about the importance of this integration from his perspective. Then I will finish sharing some things and some statistics showing the savings from fully integrating these two areas. We will then field some questions from our attendees. So Dr. Mark, would you like to take things and talk a little bit about this integration between mental and physical health?
Yeah, thank you very much, Daryl. And thanks everybody for joining in and listening. And I think it's really interesting. Had we had this conversation maybe 4 or 5 months ago, it might resonate differently with people. But I think this pandemic has really exposed an underlying need that we all knew was there if we're in the industry, but didn't really know how to translate that into the general population. But I think what this pandemic has really done is expose the idea that mental health in this country is vastly underserved. And the understanding of how important mental health is in conjunction with physical health, I don't think that you can minimize those two categories without creating some synonymous conversations that involve the mental health component and the physical. And I would say that primary care, is obviously, that's kind of where my passion lives, trying to make it better, trying to make it more accessible and more affordable, and really understanding that primary care is just one component of a person's whole health, right? And emotional health and behavioral health component really has an impact on primary care, right? So we were talking a little bit earlier with, if you have a patient that yesterday didn't know they had a diagnosis, and today they saw the doctor and were diagnosed with diabetes, that's an extremely life-changing diagnosis, and it has an emotional impact associated with that. And if you're not cognizant of understanding the correlation between mental health and wellness and chronic disease management, if you're not addressing both of those by integrating them, you're only solving half the problem. You know, mental health is really a true underlying successor to true wellness for an individual. So if you're not mentally well and you're not emotionally well, managing your disease is much more complicated. Taking your medicines on a daily basis, getting your exercise, changing your nutrition or your dietary intake. All of those things are imperative to understand how that impacts an individual when you have a diagnosis of a chronic disease. And so I think what COVID has done, not that we're all tired of hearing about COVID at the end of the day, but I think what it has done is it's exposed the idea that mental health is a problem in this country, and it's okay to feel anxious, and it's okay to feel depressed, and it's okay to be scared. It doesn't mean you're a weaker human being because you've acknowledged that you're fearful of some things that are out of your control. And so I think what we've discovered on the primary care side is that willingness of an individual to admit that there's something wrong with them, and it's okay, and integrating that with their primary care physician and the mental therapist or the behavioral therapist has been enormous to true wellness for an individual, wellness for the chronic disease management, wellness for the emotional well-being, wellness for the physical and spiritual component of being a human being. So the integration of mental health and clinical health is imperative to the success of managing whatever your problems are, whether it's disease related or whether it's truly just situational, depression, anxiety, panic disorder, you name it. When you integrate things together, things tend to be much more impactful long-term for the individual.
Dr. Mark, talk a little bit about direct primary care, because I know that's your passion, and how direct primary care has been able to, because of some of the alignment of incentives, focus more on that integration. And then let's talk a little bit about what are the key catalysts, even outside of a direct primary care environment, that are important to bring this integration together. Because it's intuitive that it's important, but the hard thing is, how do we do it?
Yeah, I think direct primary care in a nutshell was really created by physicians out of the dysfunction of the fee-for-service system. And when we say fee-for-service system, that's the healthcare system that everybody's used to. You go and see your doctor, you pay them a co-payment, your doctor then bills an encounter and sends it off to the insurance carrier, and then the insurance carrier sends a payment to the doctor. And that's how kind of the business stays afloat. What's happened during that process is primary care physicians, year over year, have to see more patients a day to make the same money they were making in the previous year. So they're not getting ahead, they're just trying to keep up with inflation. And so you look back maybe 30 years ago where your family doctor maybe saw 10 or 15 patients a day, and you can get in to see your doctor, it worked well. Mm-hmm. But as physicians needed to see 15 to 20 to 25 to 30 patients a day in the same 8 or 9 hours a day that they were practicing medicine, it made it really difficult for patients to get access to their family doctor. And when I say family doctor, I want people to remember what that is, right? I think family medicine has kind of been dumbed down a little bit over the last couple of decades. Family medicine historically was delivering babies and taking care of your grandparents and everything in between. And they managed 80 to 90% of anything that ever happened to you. If they sent you to a doctor to go see for your heart, they were communicating with that doctor and then bringing you back into the practice, and they were managing you based on what that specialist told you to do. Because we don't have time in family medicine to do that in the fee-for-service environment by seeing 30 people, urgent care has popped up. It solved the access problem for patients. You can get seen today, but if you're seen 10 times this year in an urgent care facility, you're probably seen by 10 different doctors, and they don't really concern themselves with your diabetes. They're treating your smashed finger or your sore throat. Direct primary care was really a way to change the economics of primary care. We moved away from having to submit a claim for the insurance company to reimburse us. We went back to the point of saying, okay, let's just have the patient pay for our services, but let's make this in a very affordable approach for the patients. And think of it like Netflix. Netflix, you can pay, your $30 a month, and you can see as many movies as you want during that month. Or this month, you may not see any movies, but you're okay with understanding that you can use it as much as you want or not use it at all. Direct primary care is the same. Average across the country is about $70 a month for an individual, and you can see your doctor 20 times this month if you wanted to. There's no co-payments. The doctor doesn't bill insurance companies. And therefore, the doctor can then see fewer patients in a day because they've already been paid for those encounters. So a traditional family medicine doctor sees about 25 patients a day. A traditional direct primary care physician sees about 6 to 10 patients a day. So now your doctor has time, an hour if they need to spend with a patient to really educate them about their problem, whether it's diabetes, whether it's hypertension, whether it's depression or anxiety. And then when you pair behavioral health into that same conversation, now you have your family doctor and your therapist sitting next to each other talking to you about this triad of problems. The success rate of fixing them is exponential compared to, well, I only have 10 minutes to spend with you. I'll address this and this, but you're going to have to come back, or we're going to refer you out to here. Direct primary care has solved that problem for access as well as the cost component, and we're redefining family medicine back to where it was when you actually knew who your doctor was and you can get a hold of them, and when you called them, they knew who you were.
Well, and a lot of people think that direct primary care is something that an individual, just as an individual, decides whether they want to participate in. You have led a movement where employers have offered direct primary care as a level of the benefits that they offer. Do you want to talk a little bit about how employers can actually play a huge role in driving people into a more integrated form of primary care?
Yeah, absolutely. So we take care of hundreds of companies. Some companies that are thousands of employees, and some companies that have 3. We take care of everything in between. The benefit of this is when you open up access to your primary care physician, and you do it in a way that is affordable and accessible, you start eliminating the need for your urgent care. You eliminate the need for the emergency department. You eliminate the need for specialty referrals because your family physician can manage the vast majority of those problems. And you only use referrals for somebody that actually needs to take action on that specialty, meaning that if I'm a family doctor and I identify somebody as having a heart disease, I don't have to send them to the cardiologist just to say, well, they've got high blood pressure and I don't really know what to do. We're going to manage all the way up to the point of saying, let's risk stratify this patient. And hey, everything I've done is still not working. Now we're going to send them to a specialist, but not early in the process. We're going to send them later in the process. So we're all optimizing our care. The way that this benefits an employer is that it changes how you're spending money in the healthcare space on your employee, because your employees are not going to the emergency department because they can't access their doctor. They're not going to the urgent care because they can't access their doctor. Milliman did a phenomenal study recently in direct primary care, and it was based on actuaries. And so they looked at, what does direct primary care do on an employer basis? And what they showed was that there was a 53% reduction in emergency department use. There was a 40-something% reduction in emergency room claims. There was 25% reduction in hospitalizations for patients in direct primary care. And so you really quickly learn the power of what primary care does when your doctor is accessible. And if you took away the cost component for your employee to access that doctor, it's amazing how much they engage with their physician. A quick statistic that I always like educating people on is that in the fee-for-service or the traditional healthcare, health insurance component, patients typically see their doctor 1.3 times per year. That means maybe you did your wellness visit and maybe you got sick enough during the year that you can get in and see your doctor. So 1.3 times a year you're seeing your physician. Inside of direct primary care, it's 4 to 5 times face-to-face per patient per year. But what's really interesting is because now your physicians are accessible through telemedicine and phone calls and emails and text messages, we find that the interactions are 5 to 1 on the technology side. So for every one visit face-to-face, you're having 5 additional encounters through your text messages or your emails. And so on average, direct primary care, we see our patients between 10 and 15 times a year. And it's not because they're sick, it's because they want to be well. And that you've eliminated the barrier to access and cost, that now instead of going to Google and trying to figure out what's wrong with you, you actually call your doctor that says, hey, Daryl, how are you doing today? What's going on? Oh, you have questions about this disease? Yeah, absolutely. Let's talk about it. And now you're engaged because you want to be well. That's the power of direct primary care and how we've, from an employer standpoint, and what's been interesting on the employer side, Daryl, is the fact that employers started using us as a true benefit, direct primary care, with their employees. So they started using it as a retention tool. They started using it as a recruitment tool, let alone the money that you're saving by managing the employees more efficiently and effectively. We have 2 fairly large national clients. They both did internal surveys after about 2 years on PeakMed. And they asked the employees the top 10 benefits that the employer offers. Everything from their employer contributions to their HSAs, the 401 retirements, their benefits, their dental, everything. The number 1 and number 2 categories for both those organizations was direct primary care. And that speaks volumes to the employer that offers it, and then also what the employees actually are looking for as a benefit. So it's worked. It's a win-win scenario.
Well, and a couple of things to add to that. My experience in that I get to present to groups of CEOs regularly is when I ask them, why in the world are you willing to spend so much money in offering benefits to your employees? It's often the second or third largest cost of doing business. The very first thing they say when you ask them that question is, I want to attract and retain employees. Number 1. And if you look at all of the innovative health plan designs today that are really breaking out across the country, and they're focused on, again, building a benefit that attracts and retains employees, it all starts with primary care and access to healthcare. And the fact that these systems are much better at advocating for the patient. They're much better at integrating the care of medical and behavioral. The whole focus is on easy, immediate access and having a relationship with the healthcare system. So it's wonderful to see that popping up around the country, and I believe that's where we're headed. And I think direct primary care is a great solution that employers can implement to really get full advantage of that. Let's talk a little bit about, for those plans that are not currently doing direct primary care, and even those who are, the other important catalysts who can be very influential at making sure that there's an integration. So clearly, the quarterback, the primary care physician, no one's more important than that player. But we found that a good case manager who really understands the need to pull the behavioral and medical together is incredibly powerful integration as well. A health coach, when you've got people on a regular basis talking to a health coach about their overall well-being and emotional well-being and physical and nutritional, that coach can play a significant role in integrating and pushing those two sides to be working together. And then the other one is a good employee assistance program where people do access emotional support. And when a good EAP truly integrates and pushes and coordinates with primary care, those are all different levels of the system that can help to influence this integration. Do you have any comments on any of those?
Yeah, I think everything that you just mentioned is critical to the success of a human being. When we talk about walking them through the journey in healthcare, primary care physicians can only do so much by themselves. Case managers can only do so much by themselves. Therapists can only do so much by themselves. You have to have integration of all of these components seamlessly throughout the process. And you have to have somebody that's managing all of these different facets of care. Case management is a great point, right? So you have your family physician, you have your therapist, you have your specialist, there is a lot of moving pieces in taking care of a human being. If you're young and healthy and you're 5 or 10 years old, this is probably not as relevant for you because they're young and healthy.
Right.
Those aren't the ones that are spending a bunch of money in the healthcare space. And historically, that's why children aren't the big consumers of the healthcare dollar. It's the patients that have multiple issues. It's the patients that have comorbidities. It's the patients that have multiple problems that need help navigating those problems because it's too overwhelming for one person to process. So having a case manager help them navigate through that process. Having a health coach augmenting what the family physician is saying and what the mental health provider is saying, and coordinating all of those efforts is key critical to the success of somebody. I think we're each successful in our own little silos. I'm successful as a family doctor. You're successful as a behavioral therapist. You're successful as a health coach. You're successful as a case manager. And all of those have little wins in those silos. And that's wonderful. But if you're really trying to optimize that, you have to put all of those silos into one silo that they all communicate and talk. And when that happens, you elevate the success of that human being that we're all dealing with. And that's the true power of what you just described.
What I'd like to do now, Dr. Mark, is share with the group some statistics that Milliman put together for the American Psychiatric Association a few years ago, showing the economic impact of integrating medical and behavioral care. So to go through this quick little show, basically, they were asked to look at this need for integration. They called it IMBH. And based on the experience of recent successful IMBH programs, the report estimated the portion of the elevated healthcare costs that can be controlled through such programs. So medical costs and chronic behavioral comorbidities. When someone has a comorbid chronic condition with a mental health or substance use disorder condition, they're 2 to 3 times higher in costs. That represented, according to Milliman, $293 billion back in 2012 of additional healthcare costs incurred by not integrating. Most of the increase in cost for those with the comorbid condition is attributed to the medical services, not the behavioral health. So it's not the fact that they need more therapy that's the problem. It's the fact that because we're not addressing the behavioral, the medical costs are exploding. So if you look at the additional spending that may be saved through effective integration of care, 9 to 16% of the $293 billion they said was very easy, could be saved by just integrating. That's 26 to 43 billion dollars. Let's put that in perspective. 35 billion is the projected total national expenditures for mental health and substance abuse in 2014. So there was more to be saved in the integration and dealing with these people with these comorbid conditions than the entire amount of money spent through psychologists, psychiatrists, and mental health professionals together. Now take a look at what Milliman then broke out as the commercial portion. And they found that the largest opportunity for savings was through employer-sponsored health plans. The projected potential savings in that category was $15.8 to $31 billion. Putting that in perspective, the entire spend on total national healthcare expenditures back in 2012 was $922 billion. That was private health insurance. That's 1.7 to 3.4% could be saved by just integrating these two areas. Now let's convert that with some simple math into what that looks like on a per employee per month basis. That's about $17 to $34 per employee per month back in 2012, additional savings through integrating the care. Now apply medical inflation, bring that up to 2018, still a couple years ago, that's $22 to $44 per employee per month by just pushing this integration. Now put that in perspective. Employers, 101 to 250 employers size on average spend about $2.73 per employee per month for an employee assistance program, which is the preventive level of care that can be a good instrument in integrating. Look at all of the money that could be spent by could be saved by spending a little bit more money in an EAP that helps you integrate. You'll double that, and you still got a huge ROI in terms of savings that can be had by really integrating mental health and medical.
Yeah.
Now I'd like to share with you just quickly, before we take some questions and answers, again, the program that we've been running for 23 years, just one example of a group with 50,000 members, the ROI on fully integrating medical and behavioral. Now, an actuarial benchmark of this group was that about $21.38 PEPM would be what would be normally spent. We spent considerably less, 23% less than that, $16.51 per employee per month, and that's adjusted for both region, plan, and industry type, creating claim savings of $4.86 PEPM. Now, over 2016 to 2018, that was $5 million in behavioral health care savings just on the behavioral health care side. Now we put that into the additional savings from the medical side, and the ROI was somewhere between 7 to 1, and some estimates are even greater than that, just between 2016 and 2018. So again, just wanted to share with you some of the dollars that can be saved by really pushing an integration between these two. Now we're going to be addressing a number of other topics over the next few weeks. In fact, we've got probably 12 to 15 different secret sauces that we've learned, not just the integration between the medical and behavioral, but many other. And probably the most important thing we've learned, by far the greatest ROI, comes from early intervention. People wait on average 10 years after mental health symptoms are presented before they get help. And 60%, almost 60% of people never get help. It's really the greatest savings potential is early intervention and getting those people to get care early. We're going to be addressing that in some of our future webinars. But let's open it up in the last few minutes we've got and see if we've got any questions by our participants and that we can address as a group. So use your control box, and if you'd like to send in a question, we'll be happy to answer those. So if anybody has any questions, send those in, and Dr. Mark and I will try to address those. Any additional comments while we're waiting to see if any questions come in, Dr. Mark?
Yeah, I think that Milliman study is pretty impressive in terms of the integration. I didn't actually, always in theories it works well. I think when you put numbers to it, it really puts it in perspective, realizing, holy crap, how much money do we waste in the healthcare space for ineffective care?
Right.
I think it's amazing to me, and we've seen it on the family practice side and the total cost of care, but behavioral health has always been something that's challenging to quantify, right? Because because the impact of behavioral health on a human being is sometimes life-saving, right? How do you quantify that? The fact that you can put numbers to it and justify spending it is all the reason to say, why aren't more people doing this? Why aren't we trying to solve this problem? And what's the challenge here? So you've always been this thought leader and somebody that's been paving the way for a long, long time now for behavioral health, and maybe the rest of us are just catching up. So it's nice to be part of the conversation. It's nice to see the economics behind this thing, and I just wish that we could do a better job of getting the message out and getting people to understand the power of integrating these things together. And ultimately, you're going to drive the cost of care down in this country, which is a win for everybody. Yeah, it's just, everybody has agendas, and sometimes the agendas are financially driven and not health driven. And that's the challenge sometimes in healthcare.
Right. So we don't have any questions from the group today, which is fine, but I do want to just in closing mention that these webinars are being sponsored by a program that our company is just launching called Resilience Pro. And there's a handout that employers are welcome to, or anyone that's on can download from the control box. We'll also be sending that out to you post the huddle, a brochure describing the services of this Resilience Pro that really takes all of the things we've learned over the last 23 years and packages them to an a la carte solution that employers can pick and choose from, or bring the whole integration together to better manage population mental health. We did have one final question. Let me take a look at that real quickly. How is primary care set up for all employees? That's a pretty broad question. Maybe we can address that at our next meeting or our next huddle. And we're out of time. So Dr. Mark, thank you so much for your time today, for being a part of this. And let's stay in touch. And we thank everyone that participated.
Thanks,
please join us in an upcoming webinar.
Really appreciate it. Thanks, and have a great rest of your day.
Thanks, you too. Bye now.
Bye.